depression. One is somebody who's sad and crying. You might think of a melancholy person who is tortured by demons, such as this man. A kind of a look of apathy, someone who doesn't seem to care about a lot of things. And then what I always think of is Abraham Lincoln. A lot of people today think he may have had a clinical depression back in the day. So those pictures give an idea of what depression is, but this is how we define it medically. This is what we mean when we say major depression. So major depressive disorder is the technical name that we give it, or MDD for short. And we define it based on the DSM-5 criteria. That's the Diagnostic and Statistical Manual of Mental Disorders that was made by the Board of Psychiatry. And you need 2 weeks of at least 5 of these list of symptoms. Number 1, depressed mood. Number 2, a loss of interest in activities or things that you used to do for pleasure. And the fancy name for that is anhedonia. Fatigue or low energy. Changes in weight, and that can be either loss or gain of weight. Changes in sleep, either being insomnia or too much sleep. Motor slowness or motor agitation, not being able to sit still. Feelings of worthlessness or guilt, decreased or impaired concentration or memory, and thoughts of death or suicide. Now, a lot of you may be reading this list and thinking, gosh, a lot of these apply to me, and that's why I've boxed a few of these in red. A lot of these symptoms, they might sound familiar from the first talk we had. These are some of the cardinal symptoms of Parkinson's disease. So sometimes it can be very difficult to differentiate the two from each other. Fatigue or low energy, common from Parkinson's itself. Changes in weight. Weight loss is often a very big problem because of swallowing difficulty later on. Insomnia, we just spent 30 minutes talking about sleep problems. Motor slowness, that's the definition of Parkinson's disease. And cognitive changes can come on later. So it can be really difficult to recognize depression and accurately diagnose it. We really rely on those first 2 symptoms, depressed mood and loss of interest in activity. I put stars by those because we need at least one of those 2 to diagnose it. And probably the most important bit is at the bottom. They have to cause enough distress to cause problems in your life or impair your life in some way. Risk factors for depression, aside from having Parkinson's disease, is being female, having a younger onset of symptoms, less than 40 years old is what we usually define that as. Cognitive impairment or dementia increases risk for depression. Other medical problems that may limit your ability to function, such as heart disease, high blood pressure, arthritis, and if you have a family history of depression, that also greatly increases your risk of contracting depression. I mentioned before, in Parkinson's disease, it can be difficult to diagnose because many symptoms overlap, those 5 big ones that I mentioned before. Secondly, the facial expression in Parkinson's disease. Sometimes it looks like a mask. You have trouble expressing yourself. Even if you're not depressed, people may think, this guy's depressed because he sure doesn't express himself very much. It presents itself differently in Parkinson's disease as compared to your garden variety depression. Regular depression, you may have depressed mood for weeks and weeks on end. It becomes pretty clear. Whereas Parkinson's, it can fluctuate from week to week or even throughout the day. And due to the overlap, people don't recognize or they're unable to explain, I'm depressed, either because of cognitive impairment or something else. Apathy. A lot of us may think of grumpy cat when we think of apathy. But we're not all grumpy cats. So what is apathy? Apathy it's a lack of motivation, a failure to initiate behaviors or goal-directed behaviors that you would do before. So examples of this: difficulty getting started doing things, initiating, needing constant prompting or reminding from caregivers or family, low activities levels in general, even if they're able to be active, they just aren't. Lack of effort, not completing tasks that were started, and not being concerned about things that they used to be concerned about. A big change. I don't know if this is sounding familiar to anybody in the room right now, but that's what I mean when I say apathy. It can be seen often with depression, but a lot of times in Parkinson's, it can be seen alone. There's a big overlap between depression and apathy. Pure depression is uncommon. There's almost always some element of apathy in there, but there's a lot of people out there with apathy without depression. How do you differentiate the two? Depression, I think of as a mood disorder, sadness, feeling worthless, feeling guilty, hopeless, and sometimes suicidal ideation. Apathy, motivational disorder, no initiative, less interest, indifference emotionally, and decreased reactivity emotionally. Now, there's a little bit of overlap between the two, and that is that inability to feel pleasure like you used to, loss of interest in activity, and just slowness overall. But those are the things that I look for in trying to differentiate the two. And what's the big deal about apathy? Why is that harmful? They just don't want to do things. Well, when you don't want to do things, you don't do things. And we know in Parkinson's disease, that's kind of the enemy. We've been talking all day about how exercise is important. When you've got apathy, you don't want to exercise. So things get worse. It causes increased caregiver stress and distress. You always have to remind people to do these things. It becomes a full-time job to just be motivating for a Parkinson's patient with apathy. Poor treatment compliance. Why would you take your medicine if you didn't want to do anything? And it leads to worse rehabilitation outcome when working with physical therapy. Once again, lack of effort, low participation. So it can be very harmful. It sounds benign, but it can be very harmful. Leads to higher morbidity and mortality, people who have apathy. And lastly, I want to talk about anxiety. What is an anxiety disorder? What do I mean by that? Because we all experience anxiety from time to time. I have some degree of anxiety right now. But this is feelings of constant worry or nervousness that are present more than what we would consider to be normal. And like with depression before, it has to have a significant impact on your life, daily functioning or quality of life. So what's the difference between regular anxiety and an anxiety disorder? So regular anxiety, it's a normal reaction to something, a stressor in your life. Like you've got a big test coming up, or you have to talk in front of 800 people. It has a start and an ending point. I'm going to get off this stage, I'm going to feel great. Then it's Cheri Prince's time to come up here. It can be helpful. It can be very, very useful. So I've got a test coming up. I'm going to study for several days, probably longer than that. Might pull an all-nighter. It helps. And then afterwards, relaxing, you feel better. So regular anxiety, often a good thing. Anxiety disorders come out of nowhere. It's a disproportionate response to what the stressor is. Can't stop worrying about it. Even if it's, all of us think, what the heck are you worrying about this for? Can't stop thinking about it. Goes on for weeks, doesn't end when the stressor comes or a new stressor comes along to replace it. It can lead to physical manifestation of symptoms, sweating, palpitations. Your tremor might get a lot worse. It just takes over your life. Common manifestations of an anxiety disorder: excessive worry, avoiding things because they cause stress and anxiety, constantly seeking reassurance. It can get quite irritating and annoying to caregivers. They get easily upset about little things that normally wouldn't upset them. impairs sleep because you can't stop thinking about things. It takes over your mind and you have racing thoughts at night. Eating disorders, and this usually leads to weight loss or bulimia or anorexia in Parkinson's disease. Most of you know about the interaction between levodopa and eating, like protein. Some people become so anxious about that they just don't eat. That's how severe it can be. And it can lead to panic attacks as well. There are a few different types of anxiety disorders. The three most common in Parkinson's disease are a generalized anxiety disorder, and that's exactly what it sounds like. You're worrying about everything all the time. There's social anxiety, which is limited to social situations. Perhaps you're very self-conscious about your symptoms. You don't want to go out in public because that embarrasses you. And anxiety attacks or panic attacks, where you're doing fine, and then all of a sudden you're not doing fine, and you feel like you're going to die, and it's just extreme anxiety. So why does this cause problems, aside from all the problems we just talked about? Number one, it exacerbates the symptoms of Parkinson's disease. It leads to impaired concentration and memory. You're so busy thinking about these things that worry you, you can't concentrate on the other tasks of life. And it might even, sometimes it looks like early onset dementia because the concentration can be that impaired. Sleep problems, you worry about medication side effects, what can lead to medication noncompliance, and a lot of friction with friends and family because it gets irritating sometimes. And lastly, I do want to talk about suicide. Approximately 30% of Parkinson's patients have at least had thoughts about suicide at some point. A Danish study found that people with Parkinson's were over 2 times more likely to attempt or commit suicide compared to people without. So when you or a loved one expresses thoughts or you have worried that they may commit suicide, I want you to do these 4 things. Number 1, use your social support network, and I'll talk about that a little bit more later. Find a support group, stay socially engaged. Don't isolate, as can be the tendency to do during those times. Seek professional help, either from your neurologist or a psychiatrist or a psychologist or a social worker. Be sure to prioritize self-care. A lot of times we focus on other things in our life, but when we have thoughts of suicide, it's important to take care of yourself. And if things become dire, don't forget to use emergency services. Call 911 if you have to. I've got these suicide resources for everybody. It should be in the handout here, because I know that's a lot to write down in a small amount of time. So how do we treat mental health disorder? There's 4 main pillars that we think about from the medical standpoint. That's, of course, medications, but also psychotherapy, exercise and other complementary techniques, and then that social support I was mentioning before. So the medications for depression. These medications have been studied for a long time, but not specifically in Parkinson's disease, mostly just the general population. And they've shown to have very good effect in the general population. So our first-line therapy, we just use what we use for people with regular depression. These are SSRIs. Some of you might be on them. Some examples are Celexa, Paxil, Zoloft, Prozac, others like that. There's some second-line therapies here as well. I won't go into the details of all of them. Some of you are on selegiline and rasagiline. We use those mostly for the motor symptoms of Parkinson's disease, but they also have a mood effect. They were originally antidepressant medications, but now we use them more for motor Parkinson's symptoms. If things get severe, we may consider some of those ones that I put with the star, like Seroquel and Clozaril, but we kind of save those for refractory cases. Medications for anxiety, they are very similar to medications for depression. Once again, no specific trials for Parkinson's disease compared to normal anxiety. But the first-line therapies, they're exactly the same. The SSRIs, In severe cases or in panic attacks, we may consider some benzodiazepines like Klonopin or Ativan, but we prefer to stick to the SSRIs. Better benefit, less side effects, and that's always what we're looking for when we prescribe medications. Now, apathy, very difficult to treat in Parkinson's disease. That's one reason why it's such a big problem. It doesn't seem to respond to medications like depression and anxiety. And there are no approved medications for apathy. Now, of course, we try some. We know that dopamine is kind of the motivating chemical in the brain. So it stands to reason, since dopamine is lacking in the brain, that's a big cause of apathy. So sometimes optimizing the medication regimen for your Parkinson's can be very helpful. So we'll try adjusting the levodopa, maybe adding one of those dopamine agonists that we talked about before. Sometimes that helps, sometimes it doesn't. So we'll consider some other medications, and sometimes we consider the use of stimulants like methylphenidate or Adderall if we need to. Sometimes that can be helpful. Special considerations for Parkinson's disease. We saw this graph earlier when Dr. Sire was talking, how there can be a fluctuation in the level of medications. Not only can that affect motor symptoms of Parkinson's disease, it also affects non-motor, such as mood. I have several patients who, as they're wearing off, as they can tell the levodopa is wearing off, start getting really, really anxious. Number one, because their symptoms are coming back, and number two, the dopamine is dropping in their brain. So sometimes getting a longer acting form of levodopa or just taking it more frequently can be very helpful. Other medical interventions we do for depression and anxiety, deep brain stimulation, that has been shown to have a positive effect on mood. Electroconvulsive therapy, we do that sometimes. Now, probably some people have an image of their head of what they've seen in movies of people getting electroconvulsive therapy. It's not that bad. People tolerate it really well, and it works really well for refractory depression. We don't do it on everybody with depression, of course. But it is safe and effective, works really, really well. Unless you have deep brain stimulation, then we can't do it. And the most recently approved treatment for depression is transcranial magnetic stimulation, and not as violent as electroconvulsive therapy. They put just an electromagnetic stimulator on your head, apply a gentle pulse, and that does seem to help depression quite a bit in some people. I do have some patients that get that with good benefit. So they're coming out with new things all the time. Psychotherapy, one of those pillars that we talked about earlier. Very helpful, and it doesn't come with side effects of medication, so that's one of the first things that we always start with. They use something called cognitive behavioral therapy, or CBT, and that's that talking therapy that we're all familiar with psychologists. They aim to change negative thinking habits and behavior patterns and replace it with positive thinking habits and patterns. It's the most studied intervention for depression, and it is shown to be as effective, if not more, than medication. So that's always the first one that we like to go to. And if anybody has any interest in seeing a psychologist for this, there's a website right there you can go to that provides local resources. Exercise, not only important for the motor symptoms of Parkinson's disease, also very important for the mood symptoms of Parkinson's disease. It improves everything. So if you're not exercising, you should start exercising. You heard it here first, folks. Walking, stretching, whatever gets you moving, that's what we should do. Then there's several other non-medication or medical therapies that we can do. Light therapy, like we were talking about before. When I first started working at UNMC, I had an office without a window in a corner, and in the winter months, it really did start to take a toll on me. I went on Amazon, I bought a UV light, and I gotta tell you, it works. It works for me, so give that one a try. Relaxation techniques, meditation, that one's good to do even if you're not depressed. Music therapy, There's a whole lot of things that we can do to try and help with mood. And social support. What do I mean by social support? This is the network of people that you rely on in times of need, and vice versa. They rely on you in times of need. So this is family, friends, your coworkers, religious community, anybody that you interact with on a regular basis. They help you build healthy habits, cope in times of stress, and they are a good motivating factor for you. They can see who you are, how you've changed over time, and that you need to get your stuff together. They can be a good motivator sometimes. And they provide 3 types of support. Number 1, emotional support when you're feeling down. They can provide a kind of a shoulder and an ear to listen. Instrumental support, that means providing physical resources for you, meals, rides when you need them, and informational support, advice, guidance. That's where a support group can be really, really helpful. So if you're not involved in a support group, I highly recommend you get involved in one. This is how you can find information to be part of one. There's several in Lincoln and Omaha. There's these websites right here that you can go to. Once again, this is in the handout. Also, lots of online support groups too. If you're to the point where you can't get out, or you're so apathetic that you can't get out, there's online support groups too. And this is not just for patients, this is for caregivers as well. This is my social support. This is Mackie Boy. He's 2.5. This is him in Norway, enjoying the countryside. You might think he looks very Norwegian. Customs thought so too. They tried to keep him. He was a squirrel for Halloween. I should have updated the photo, but trust me, he was cute. So here's some take-home points. Depression, anxiety, and apathy, extremely common in Parkinson's disease. At least a third of the room here has it. This is not a personal failing or a weakness. It is part of Parkinson's. It's a chemical imbalance in the brain. It affects your life as much as the motor symptoms do. It increases risk for suicide, and it is underdiagnosed. Recognition is the key. As we talked about before, recognition is difficult to do. There's a lot of overlap with those Parkinson's symptoms. Always discuss your mental health annually with your doctor if you don't already. Sometimes we forget to ask about it, so be sure to bring it up. And be sure to bring a family member or a friend. They are a very valuable resource when it comes to identifying these types of symptoms. Once again, thanks everybody for coming. Stay warm, enjoy the rest of the day. Up next is Cheri Prince. Many of you know her and have met her already. She's the Director of Therapy at the Heartland Neurological Wellness and Therapy Center. Very happy to have her today. Thanks again.
Hello, everyone. Everybody's anxious for lunch and probably ready to get moving, so I'll try and make this not too painful. As Dr. Woodward said, my name's Cheri Prince. I'm a physical therapist and have really had the privilege of working in the Parkinson's community for many years now. I'm very fortunate that I get to work in the Parkinson's community every day now, so I'm very grateful to be here. Today we're going to talk about exercise in Parkinson's disease. Some of you may have heard me speak about Parkinson's and exercise before, and I'm excited today to kind of take a little bit of a deeper dive into some issues. So today's discussion, I have to remember to advance my slides, sorry. Today's discussion is, why is exercise important in Parkinson's disease, and what can it do for you? Luckily, we've had a little bit of an introduction to that already today. How do we need to exercise to achieve these outcomes? And I think that's probably the biggest piece that we're going to talk about today, is the how we need to do it. And then specifically, kind of what the role of some specific types of exercise are. So you'll see as I talk that there are multiple kinds of exercise that are recommended for Parkinson's disease. We're going to talk very specifically about 3 of them today: aerobic exercise, skill-based exercise, and dual task exercise. The first thing we're going to talk about is exercise is medicine. So we've talked a lot about medications already today, but I want you to shift gears a little bit and think about how we can apply exercise and start thinking about exercise as medicine. There's a lot of research out there today that says, and as was already mentioned, that exercise can help you manage your Parkinson's disease, and not only that, it can help slow the progression of your Parkinson's disease. So we have to really start thinking about exercise as important as your medications. And not as an optional. So sometimes people think, I should exercise because it will be good for me, but we really need to start shifting our mind to thinking, I need to exercise because it's how I'm going to be successful in my journey with Parkinson's disease. So if you start to think about exercise as medicine, which is what I'm hoping you'll do, it kind of shifts the way you think. So when you think about how you take medication, it matters how you take it, right? You take it according to a prescription. You don't just get a bottle of medication and start taking it whenever you want to at home. So you take it in a prescribed manner, and that's what we want to do with exercise. It matters if you miss doses, right? We don't want to miss doses of our medication. That's has a very negative outcome on our health, whether it's a Parkinson's medication or another medication. And so we want to start thinking about exercise that way too. We don't want to miss doses. We want to get all of our doses of exercise in, just as we would our medication. And exercise needs to be prescribed for you by someone with experience in Parkinson's disease. It is very important, you'll see today, how we exercise, and so you need to really seek out someone that knows what's important in exercise for Parkinson's disease, and that's who needs to help you guide how you exercise. Okay, we're going to spend a minute or two here on the benefits of exercise, some related to Parkinson's, some in general. Obviously, exercise in the general population has been well researched. We know there are many cardiovascular health benefits of exercise. We know it helps us control our weight. We know all those things. But today, as we've learned, Parkinson's is very related as a brain disease. And so how does exercise affect the brain? Exercise is important because it improves brain function. Improved heart and lung function equals improved motor function or improved movement. It also improves attention and cognitive speed. It improves something called executive function. Executive function is sort of a big blanket term for several things related to cognition. So attention, your ability to plan tasks and complete them, things like that. Also improves memory and balance, of course. Physical activity such as exercise increases something, a big name, brain-derived neurotrophic factors, or BDNF, we're going to call it. And that promotes a big word called neuroplasticity. We're going to talk more about neuroplasticity in just a minute. Neuroplasticity helps us change how we move, and we're going to talk about how to achieve that. The promotion of neuroplasticity provides benefits such as, again, improved motor functioning, brain functioning, and that is where we really get this potential slowing of the progression and changing that course of the Parkinson's disease that we want. So BDNF is a protein in your brain that is in charge of creating and controlling the growth of neurons. These levels of this BDNF are lowered in neurodegenerative diseases such as Parkinson's disease. So that if we know that if exercise increases our BDNF, that makes sense that would help us promote neuroplasticity. So some of these slides are a little hard to read, but I'll let you know where you can find these resources as well. You can always contact me or stop out at our booth and we can help you. But this is actually a resource from the Parkinson's Foundation, and they actually have a booth here today as well. They did a lot of study related to exercise in Parkinson's disease, and last year came out with some kind of formal recommendations. So basically, what this is saying is that a Parkinson's disease exercise program should be kind of well-rounded. So there's not one type of exercise that's beneficial, but we need multiple kinds of exercise to kind of have that perfect program. So the recommendations that they came out with are that you want aerobic activity 3 days a week for at least 30 minutes, strength training 2 to 3 non-consecutive days of the week for 30 minutes, balance, agility, and dual task training 2 to 3 days a week, and stretching at least 2 to 3 days a week, with daily being most effective. It sounds like a lot, doesn't it? And it is. But if you get given a prescription of medication and it's said to be taken daily, there's a reason for that, and it's the same for exercise. You really, in Parkinson's, need daily movement. That is just the bottom line. One of the things I always say to most of my new patients is the good news out there in the Parkinson's world is that exercise helps Parkinson's disease. The bad news is you have to exercise every day, and that is the bottom line. And so really being connected and finding ways that you can exercise and enjoy it is going to be very important and very essential. That's also why you need somebody to help prescribe it for you, help keep you engaged, help motivate you, and then connecting with a community that can also help you exercise is going to be important. Okay, so I love this. I think it's great. It's very multifaceted. It kind of includes many things. I think the one thing that whenever you're putting together something like that is you can't maybe get into the detail of how you have to exercise in these ways, because it's kind of important. Because in theory, you really could kind of complete all of these things with a little checkbox and get them all done. But if you don't complete them in a certain way that we're going to talk about here in a minute, we may not really achieve that neuroplasticity. You'll probably still feel better if you're stretching every day, and there's going to be some benefit to you for just completing it. But if you're completing it in the way that we're going to talk about today, you're going to get that maximum benefit that's being shown in research as really creating neuroplasticity and changing the course and the trajectory of your Parkinson's disease. So this just says how we exercise is key. How we exercise is very important in achieving neuroplasticity. Okay, so this slide talks a lot about neuroplasticity and how we achieve it. Becky Farley is a physical therapist that I've learned a lot from. She was an original creator of, many of you have heard of LSVT Big or LSVT Loud. She was a co-creator of that program and really worked on a lot of research on amplitude-based therapy, which is really where Parkinson's exercise started. If we talk louder and we move bigger, we will have better movement. That's true. However, it's a little more complex than that. And so she's went on to research extensively on how we need to exercise to affect the change in the brain that we're looking for, to really get that neuroplasticity. She's applied these concepts to her exercise program, which is called POWER, or PWR, Parkinson's Wellness Recovery, and we use it a lot in our therapy sessions at Heartland and our exercise programs, and hopefully many of you are familiar with it as well. But within that POWER program, or Parkinson's Wellness Recovery, she has identified 4 ways that you really have to work in order to achieve neuroplasticity. So we're going to go through those one at a time. The first one is physical effort. We have to work hard. We have to work harder than we would self-select to work. So they have done a lot of research that says most of us, myself included, Parkinson's included, not Parkinson's included, if we get on a exercise device or we're doing any sort of exercise program and we set out to work at what we self-select, so the pace that we would self-select that we're working hard. So if I just told you to start working hard and have a good workout, we would actually probably be at about 60%, 50 to 60% of our max heart rate. The exercise research in Parkinson's care says that we need to be working actually closer to that 80% of our max heart rate, 70 to 80%. So higher than what we would self-select to exercise. That's not judgmental of anybody's effort. That just means it actually takes more effort than what we would know to do. So again, another reason why we need a little help getting there. Attentional focus. So we need to work in a way and do exercise in a way that requires us to self-monitor how we're moving. In Parkinson's, we get an impaired perception of how our body is moving. So So your loved ones might notice that you're a little forward flexed when you're walking, that your steps are smaller, but your brain isn't necessarily giving you that message that those things are happening. You're still feeling like you're kind of walking normal. Now, if you start to have a lot of freezing or tripping or things like that, you're gonna know it, but you're not gonna have that self-perception from your brain that says, I need to take a bigger step. So we need to exercise in a way that makes us pay attention to how we're moving. So we'll get into that a little bit more in a minute. Cognitive engagement. We need to do exercise that's complex because we need our brain to be activated while we're exercising. Lots and lots of research about this that says if we are using our brain while we're exercising, we get increased benefit. The activation of your brain can be related to the exercise, or it can actually just be other things that you're having to think about. So for an example, when you're doing your exercises, instead of counting to 10 by ones, because that's the way we always count, and that's easy, your brain doesn't really have to think about counting to 10, we might count to 30 by threes, because we have to activate our brain while we're doing that. So that's just a little example of kind of that cognitive engagement. The other piece of that is we want the exercise to be complex. And sometimes I use the example of a bicep curl. If you think about a bicep curl and you're using a weight, you're just kind of flexing and straightening the elbow. It's not a complex movement. You really don't have to think about it. You would just kind of be able to continue to do it without really any effort. We want to do exercises that are complex, that we have to think about. Am I doing this exercise the right way? Are my hands where they're supposed to be? Is my head where it's supposed to be? Are my eyes where they're supposed to be? Is my foot where it's supposed to be? So complex exercises that we really have to kind of continue to attend to what we're doing is the kind of exercise we need to do in Parkinson's disease. And then emotional engagement, we have to like it. So that's a hard piece, right? Because who likes exercise? No one. So we have to find ways to be engaged in it. So that can look like a lot of different things. It can look like you love boxing, so that's a way that you can get engaged. It could be that you like dancing, so we work on dancing. It could be that you really like the people that you're exercising with, so you get involved in a group that exercises. It can be that you like music, and so you play certain music when you exercise. There's different ways that we can kind of get that emotional engagement to our exercise, but it's very important. Okay, this slide represents a study that was related specifically to two types of exercise. Conveniently, two of the three that we're going to talk about today. So this is kind of a confusing slide, but basically what it talks about is if you exercise